I'm going to take a moment to talk about some more cutting-edge treatments that are out there. One is called spinal cord stimulation, and then there will be a few others that are down the pike that you may not have heard of, if you have already heard of spinal cord stim. This is a booming technology right now. So spinal cord stimulation, I would say, is where it's at, especially if you have nerve pain or neuropathic pain, or if you've had post-laminectomy or post-surgical pain. You've already had a fusion. And that's a large population of folks, right? Spinal cord stimulation gives you the opportunity to have 24/7 coverage of the pain. Doesn't mean that it's going to be 100% gone and I'm back to 21. But it does mean that you have more control. You literally have it in your hand. So I'll get into this in a little bit. But first we have to review something really boring, and that's neuroanatomy. Okay? You have to understand, in order to understand what spinal cord stimulation can do, we have to get how the nervous system generally works. And to keep it simple, you have to think of the nervous system as a bunch of side roads that eventually converge into a main highway. And that main highway leads to its destination. And that destination is the brain. That's your end point. They didn't go any further than that. Okay, so as far as sensation, which pain is a sensation, we're talking about something going on in the nerves, and then that signal has to transfer itself to the spinal cord and then up to the brain to tell you, hey, something's really wrong. So this is a little rendition of a cross-section of the spinal cord. And I realize that this may be the first time you've seen something like this, and it may be a little tough to follow, a bunch of big words maybe. But the general idea here is that we have tissue injury in our leg, let's just say. The first nerve that takes that message, hey, there's something wrong, and takes it to the back of the spinal cord is called the first order neuron. The first order neuron's job is to relay that information to the central nervous system to say, hey guys, we have an issue out here. Let's take it up to the big guy up here and make sure that they understand what's going on, and let's get away from it. There's a little communication that occurs there at the back of the spinal cord. That communication is critical to understanding spinal cord stimulation, because there's a second neuron. We call it a second order neuron. He's the middleman, right? He's like, okay, I will take your message and I'll email it up to brain. But if we can halt that communication right there, maybe put a little spam in the email, maybe that message doesn't get there. Maybe some of the messages can get there, but not all of them. So the normal sensation of pain, I explained earlier, the definition is sensory and emotional, right? Sensory and emotional. Sensory meaning we're going to map out where the pain is in the body. So the brain then says, okay, we're talking about left lower leg, on the outside of the left lower leg. That corresponds to S1, let's say, the S1 nerve root. So the map is there. That's half of what the pain signal is. The other part of the pain signal is, well, geez, that really stinks. That pain not only hurts, but now I can't think of anything else. I can only belabor this issue about pain because it won't go away. So there's a divergence here in the brainstem, okay? It's about halfway between the spinal cord and the higher centers of the brain. The brainstem is where primitive reflexes occur. Our ability to drive heart rate, our ability to breathe, all depends on intact brainstem. Well, it is here, actually, where that pain signal divides into two components. It divides into the discrete component that maps out where the problem is and tells you how intense it is, but the other component has to do with how it affects memory, cognition, mood, attention, concentration, all these other things that pain affects. So that's going to be a little more important later on. So yes, ideally, if we can approach this communication, the email, stop the email from getting up there, then we won, right? And if we can do that on a 24/7 basis, even better. This right here is called the gate control theory. It's been around for ages, and spinal cord stimulation has manipulated this theory. What actually goes on between first order neuron and second order neuron is what we call an electric chemical reaction. In other words, the nerve is firing like electricity in the first order neuron, but when it gets to its final place to communicate, it actually communicates by chemicals. Those chemicals then trigger that second neuron to wake up and send that message along. So the middle ground here is that there's a chemical reaction that's occurring there whenever that first nerve gets to the second nerve. Spinal cord stimulation allows there to be an interruption of that electrochemical system. This is what we want in spinal cord stimulation. We don't want this when we're driving in traffic, but this is what we want. We want to close that gate. So how does spinal cord stim work? You may be wondering. Well, to keep it really simple, we have the pain signal, let's say, in the low back and leg, just as a common thing. This, by the way, could be the neck and arm. This could be nerve pain in your feet because of neuropathy. This could be pain in the thigh because I've got a pinched nerve that's in the periphery. So it doesn't always have to be back and leg necessarily, but this is the good prototype. This pain signal is traveling up, but we have some device here that's sending a signal just above to halt that signal, to stop that email message from traveling up and then realized. So the spinal cord stimulator has actually two basic functions. One is let's stop the signals from getting there, but because we're talking about this area here and what we call the dorsal part or the dorsal horn, is also inadvertently stimulating neurons in the spinal cord that subserve something called vibration. And vibration, what I mean by that is literally that buzzing sensation. So instead of getting the pain, what's experienced is a replacement with a soothing buzzing type sensation. Okay? And it's all because of the inadvertent selective activation of this part of the spinal cord that leads to vibration sense. Nowadays, Boston Scientific and spinal cord stimulator companies have gotten really sophisticated, and now they've found a way to remove that buzzing sensation because some folks don't like that. Some folks would prefer I don't want the pain. I don't need anything else. And so now we're lucky to have companies to be able to do that. So again, we're talking about before stimulation, we may be dealing with pain kind of like this. After stimulation, the red is gone and it's replaced by this kind of tingling, but not a unpleasant tingling. It's more of a pleasant tingling. This is important because when we do the stimulator trial, we will turn on the system and we'll try to figure out, are we in the right area? Did we position the lead in the right spot, the sweet spot? And how we know is because of the replacement of pain with that buzzing sensation. Yes, but I need it more down toward my foot. Right now I've got the stimulation. I can feel the vibration. It is pleasant, but it's up in my thigh. I need it down by my foot. Okay, let's reprogram and get it right. So that's the beauty behind the stimulator trial. So generally speaking, you may wonder, okay, well, how are you going to get this device in me? And in general, we're talking about this being done under local anesthetic. So it's not surgery, number one. Number two, the stimulator trial is like an epidural, not like labor epidural. This is a way for us to get to the epidural space and position a little electrode right behind the spinal cord. That sounds scary. But we have X-ray and we have good hands, and we're able to position the electrode 99 times out of 100 exactly where we want it. And we're able to get it in position above the level of where the pain is. Okay. Needle is removed, stimulator electrode still in place. Then for 3 days or so, you test it out at home. You haven't committed to any implant. There's been no scalpel surgery or anything like that. Ultimately, you're able to take it home and test it out and see if it works. No better way to get to a point where you're going to feel like, am I doing the right thing? Than to test it out, a test drive, and then be able to make kind of heads or tails. Most of the time, and I don't know, Matt's here, most of the time when we're on the table and we are doing the stimulator trial, it's an aha moment if it's going to work, usually. But that's the most gratifying thing to see when we can achieve pain relief right there on the table as soon as you turn the stimulator on. Turn the stimulator off, maybe a different story. But that just proves that we're in the right area. What's the process after the stimulator trial? Let's say it's successful and I've got greater than 50% pain relief over the 24/7 hour period. I've been able to reduce or avoid medications that I haven't been able to do for years, and I've been able to function better. Let's just say hypothetically that happens during the trial. Then the next step is to get the actual implant. And the implant is performed by a neurosurgeon. And the purpose of the implant, obviously, is to give you your life back. So how does the process work? Well, generally, we discuss it in a consultation in the clinic. And then we decide, are we going to do the trial? We do the trial, let's say it's successful. We discuss it, and then we get you implanted. The implant itself is a surgical procedure in an outpatient setting, normally. Takes the surgeon probably 30 to 45 minutes to do from beginning to end. And by 2 weeks' time, you're able to turn the stimulator on and move on. So I'm going to take a little session here and just kind of go over something about our clinic. McGreevy NeuroHealth is more than just a pain clinic, okay? And part of that reason for that is because we're trying to combine neurology and interventional pain. Those are two distinct specialties. You go out wherever, and more often than not, you're not going to have the same two in the same place. You're usually going to see a neurologist, you're going to see a pain specialist, and what have you. The point of bringing that up is that you cannot look at pain without understanding what the nervous system is going through and what's happening upstream and downstream from the problem. We can have all the tunnel vision we want, and we can be so clear as to what we think that problem is, only to fall short. So with training at Johns Hopkins, one of the things that I learned is that you have to have a backup plan. You have to look downstream, upstream, and you have to look at the whole person. Our goal is really to reduce pain and suffering, and also to keep an eye on any associated health problems that pain can cause or that of which can cause pain. We want to prevent further injury and pain. We want to protect the nervous system from further injury. We want to protect other organ systems. I'm not a cardiologist. I'm not a GI specialist. I'm not an immunologist. I'm not any of those things, but I am a physician, and I think it's our duty to look at these things. And if I can't help you with some downstream problems, we'll get you in the right hands. The key is really to see the forest or the big picture rather than getting lost in the trees. So again, goal is to improve well-being, mental health, quality of life, functioning, and to be on the cutting edge. So I'm going to take the next few moments and go over, well, okay, spinal cord stimulation, great. That sounds wonderful. Some may say, I've already tried it. Others may say, that sounds really interesting, but what else do you have? So I'm going to go into a little bit of that. Up until now, we haven't really gotten to a point in interventional pain to where we can fix the problem. We can manage it to a degree. We can manage the pain. That's a term we use, is manage, right? But is there something that can be done that's non-surgical but still be able to fix the problem? Well, there is a device that's produced by different companies, but one in particular is called the decompressor device. And it's pretty phenomenal. I've actually had experience with this in training and in practice, and have had success with discrete disc herniations. So who would be an ideal candidate? If you have degenerative disc disease, check. If I have a disc herniation, check. If I have nerve root pain because of these problems, check. This is something serious to consider. How does it work? And this device is capable of being access to the center of the disc itself. Okay, this is a disc procedure. So kind of like a spine procedure, like an epidural, but this is actually getting inside the disc itself. And the goal is to get this disc to lay off the inflamed nerve root that it's aggravating. So take a step back and look and think that if you have a nerve root problem, it's already in a tight space. The anatomy is such that there are millimeters of space around a nerve in the spine. Anything that encroaches upon that canal is going to irritate the nerve. And guess what the reaction is? The immune system then gets involved. The immune system says, hey, something wrong over here. Creates inflammation. That inflamed nerve then swells. what happens to that inflamed nerve when it swells? It's getting pinched even further. It's a self-propagating phenomenon. So this nerve has no hope. We tried the epidural to reduce the swelling on the nerve so that it'll lay off the disc, but guess what? The disc is still there. But this procedure has a mechanism where we can remove a portion of the center of the disc itself, create a relative suction, and get the herniation of the disc to suck back toward normal so it lays off the disc. Maybe you won't even need an epidural in that case, because if you remove the underlying issue, or at least reduce the problem directly, that might be the answer. So this is a procedure that we perform as well, and in the right candidate, we can see solid results. You may be wondering, well, what do my veins have to do with anything? We just talked about the spine and the nerves and whatnot. Why are we talking about veins suddenly? Leg pain, very common. Many different causes. How often do we have leg pain, but then we also have swelling in the legs? Cramping, fatigue. These are all symptoms that may be circulatory. Have we forgotten of what is in the compartment in the leg? It's not just the nerve. We're talking about blood flow also. Don't the nerves need nutrition in order to function correctly and prevent damage? The nerve needs good circulation. Well, if there's poor circulation, then we have a higher risk of having nerve issues. And circulation can occur in two directions: blood flow down and blood flow back up. And problems can occur when blood flow down doesn't quite go down and blood flow up doesn't quite go up when it's supposed to. There's a syndrome called venous insufficiency. You may have heard it, you may have it, maybe not. But the problem with this is as the years go by, just like our discs kind of degenerate, our arthritis develops, right? The valves in the veins, which are supposed to be one-way valves that promote one direction of blood flow from the legs up back toward the heart, when those valves degenerate, then there's something that's called reflux that happens, where the blood trickles back down. Gravity is pulling the blood down. Are we talking about heart failure here, where the fluid builds up? Not directly. Are we talking about liver disease, that you don't make enough albumin or enough protein to keep enough pressure in the blood and therefore it seeps out? We're not really talking about that kind of swelling. But we are talking about swelling in the legs that lead to fatigue, cramping, pain, discomfort, and things that look like neuropathy. And lo and behold, patients who have neuropathy oftentimes have circulatory problems. So there luckily is a method in order to treat, first to diagnose, okay? We use ultrasound to diagnose these veins as being a problem, because when the valves break down, the veins actually enlarge. And when the vein diameter enlarges to an excessive degree, you're not only at risk for having more swelling and more pain, but you're at risk for having blood clots like DVTs, and you're at risk of having skin breakdown because the chemicals are seeping out of the vasculature and into the tissue around it. Imagine having a compartment that now has fluid that's seeping out of its walls. That's only going to exert more pressure on the nerves, and that's also going to, ultimately, the chemicals are going to cause breakdown of the skin. What's the downstream harm of that? Ulcers, skin ulcers, amputation. So venous insufficiency is actually looked upon by Medicare and looked upon by insurance companies now as, you know what, we need to cover treatment for this early before it gets to those downstream problems. Because once you get to that point where you have skin breakdown, then we're having really difficulty with salvaging part of the limb. We perform this treatment using laser. The vein that's determined to be problematic is accessed with a catheter. Goes into the vein, and at the tip of that catheter, we have a laser, kind of like this laser pointer. And the beauty behind laser is that it can promote an incredible amount of heat. Enough heat in order to selectively treat things, okay? And ultimately, if we identify a superficial vein that is not in your best interest to keep having because all it's doing is causing more reflux and more downstream effects, we can take that superficial vein and take it out of the equation. They used to do vein stripping, leave these very big scars. Now, it's minimally invasive. A little puncture is all you have, and there are no incisions, no scalpel. The procedure takes probably 20 to 30 minutes total. We bring that catheter tip out under live ultrasound guidance and purposefully scar the vein down. It's essentially doing the same thing as taking out the vein. And we go from something like this, or worse, perhaps to something close to that. And I always look at this and say, okay, well, is this a cosmetic procedure or is this a functionally important procedure? And I always say it's medically important. This is a medically important procedure because we're preventing harm down the line. So we went from veins, now we're up to the brain again. And this is a different approach, but something that McGreevy Neurohealth is starting to bring toward the practice, and a very important asset that's highly underutilized, especially in folks who have chronic pain, but those that have memory disorders, those that have kind of that foggy brain, busy brain, difficult to carry on or keep up with conversation, and those that have pain, stress, and anxiety, that whole complex, because I see this probably more often than I don't see it in the clinic. And the reality is, we talked about pain amplification earlier, where anxiety just kind of takes pain here and lifts it up to there. There's got to be a way to settle that down. And there is a mechanism called EEG neurofeedback where this can be accomplished. Simply, somebody who has pain, stress, and anxiety, we can actually measure the brainwave activity and how fast those brain waves are actually occurring in different regions of the brain. We can do that for anybody, okay? But somebody who has pain, stress, and anxiety, it's like a computer that has 50 applications up at the same time and then suddenly just stops working. You've got this wonderful computer, right? And it's able to take up so much memory. But eventually, if too many processes are occurring at once, you've got a lot of noise, the system starts to break down. It starts to shut down. It's the same concept here. Pain, stress, and anxiety can make certain parts of the brain shut down because, well, there's just too much going on. And we can see it. We can actually visualize it because we have something called EVOX, which is a diagnostic tool that looks at the brain waves and puts it on a map to see at the higher frequencies down here, we got a lot of red, and what that red means is that you got a lot of it, a lot of fast activity in the brain. And that fast activity is in certain regions of the brain that are responsible for pain processing, for depression, anxiety, attention deficit disorder, and so forth. Well, that's enlightening, because are you saying my pain is here? No, but what we are saying is that pain has an effect on the brain for us to at least secondarily visualize it, to get some kind of clue. Well, that's great. For me, as a patient, all I see is I have colors. What good is that, right? Well, we want you green. And we want to get to normal. And there is a way to settle these brain waves down that are excessively fast, and there are ways to get the parts of the brain that are excessively slow to move quicker. And if we can normalize that, we've gotten rid of a lot of the noise, a lot of that amplification that we're seeing from the actual physical pain to the total pain. Last one, guys. Transcranial magnetic stimulation. Pretty new, pretty cutting edge. I'm really excited about it. We're getting close to bringing it in. And why are we bringing this in? Because we said earlier, pain and depression hand in hand. Sometimes we don't even know what's what. Sometimes we think, well, I've got a lot of pain, but I can't even pinpoint it. And then we realize, yeah, I'm probably depressed. I have difficulty with sleep. I've lost interest in the things I like to do. I feel guilty about the things and how the pain may affect my family members and others around me. I'm kind of a miserable person sometimes because I don't feel well. I've lost energy. I've lost concentration. I've lost attention. And in some instances, I get really sad. That's depression. Okay? That whole thing that I just went through is depression. So there is an FDA-approved treatment that's without medication and can boost the right kind of chemicals in the brain at the right location in order to make you feel better. That's called TMS. Okay? Some studies are out there, believe it or not, there's actually stimulators inside the brain that are being placed called deep brain stimulators. And this is an evolution from that. So the idea is, well, let's not do a burr hole and a craniotomy and put the patient through all this in order to deliver stimulation to certain parts of the brain. Let's do it outside of the cranium so it doesn't hurt, so it's not painful. So the patient's awake. We can monitor them. This device is a magnet. It's a coil. Now, you've heard of MRI. MRI works on the notion of exciting certain neurons with certain pulses in order to create ultimately an image. What this magnet does is it selectively targets nerve pathways in the brain that we know are implicated with depression. Okay? Well, how does that affect pain? Okay, great. You're going to get my depression under control. Okay, I'll buy that. I still have this physical problem here. I still have pain. What are you going to do about that? The reality is, you treat the depression, you're going to help the pain. Number one. It cannot be ignored. Number two, the same brain areas that are involved with that emotional side of pain, that part of the pain pathway, is lo and behold being treated with the transcranial magnetic stimulator. So you're almost killing two birds with one stone here. In Europe, there is a chronic pain indication for transcranial magnetic stimulation. In the United States, we're behind. But McGreevy NeuroHealth doesn't care about that necessarily. What we care about is there something else that we can provide that potentially could provide relief? So I'll conclude by thanking you for your attention. Not a single person fell asleep. I am really excited about that. I know it was very long-winded, and there's a lot that we covered, and there's probably a lot of questions, but I commend you for coming and hanging in there and listening. I definitely am interested in answering your questions. Thank you.